mental health and health in general during the pandemic. And so we want to introduce a topic, the COVID-19 vaccination, and we want to talk about improving confidence, equitable access, and administration of this vaccination. And our first speaker on this topic is Dr. Anna User. Dr. Anna User joined the Maternal Fetal Medicine Division at the University of Colorado in 2016 at the completion of her fellowship training. She has had the opportunity to train at the University of Vermont College of Medicine, University of Minnesota, and the University of Colorado. Dr. User is the MFM division's expert in viruses during pregnancy and has been the lead MFM in both Zika protocols and in active education on COVID and vaccines for her section. She also has a special interest in the effects of living at altitude on pregnancy, physiology, preeclampsia, and magnesium sulfate. And with that, I will turn things over to Dr. User.
Thank you so much. I'm just going to share my couple of slides here and we'll get started. So just can someone confirm you can hear me okay? All good?
Yep.
Great. So this is divided into two parts from my standpoint. One of them is, what does COVID infection itself do to women and babies during pregnancy? And then what about the vaccine do we know as far as pregnancy and fetuses and neonates? So as far as the infection itself in pregnancy, my disclosures. This is a photo of myself and my baby that has since been distributed quite widely within UC Health as far as just proof that, vaccinations during pregnancy are great. And I'm a personal advocate for it, getting my vaccines at 32 and 35 weeks pregnant. Some of these slides,
Anna, I'm sorry to interrupt. We're not seeing your slide.
Okay, let me try to fix that.
Quick check.
Yes. Okay, sorry, I think I know what I did wrong. My bad. Thank you for letting me know. Okay, does that look better?
Yes.
Okay, so my disclosures, I have no financial commercial disclosures. I am very strongly a pro-vaccine advocate, getting it for myself at 32 and 35 weeks pregnant when I was expecting last year. Because of this, I have an 8-month-old, and a lot of these slides I used with a little help from some of my fellows and colleagues in MFM, as many of us have given presentations on these topics over the last several months. As I said, my vaccines were during pregnancy, and because of this, I've become both a personal and professional advocate for vaccines in pregnancy and have been able to participate both in some local news efforts as well as internal UC Health outreach supporting the use of vaccination in pregnancy. And actually, I'm one of the data points in the VSafe data that will be part of what I present today. So we've known for a long time in pregnancy that pregnant women are more susceptible to the complications of respiratory infections and illnesses in pregnancy. And this has been shown in pneumonia. This is true for urinary tract infections or pyelonephritis in pregnancy, and also most notably the H1N1 flu, as well as SARS and MERS in the past. And now we've been able to see that this is also true for COVID as well. So when women are pregnant, they have a higher risk of severe COVID complications when compared to non-pregnant women of similar risk factors, whether that be age or other comorbidities. So pregnancy itself is an independent risk factor, and it has been shown to increase the risk for ICU admission by about 3-fold, about 2.5 increased risk of needing ECMO, and there's also an increased risk of needing mechanical ventilation for a pregnant patient, and about a 1.7 increased risk of death from COVID illness. And then these risks are additionally further increased if a woman has other comorbidities such as obesity, diabetes, or advanced maternal age. We don't have as solid of data, but it does seem to be that both Hispanic, Latinx, or Black patients are disproportionately affected by these severe maternal morbidity and mortality effects. And there's a disproportionately higher incidence of COVID-19 infection and severe complications in these populations. So as far as what we know about fetal and neonatal effects of COVID-19 infection in the mother, the initial data from the United States in 2020 suggested that preterm birth and stillbirth rates were not all that different compared to studies that looked at numbers prior to the COVID pandemic. We don't have any evidence of congenital abnormalities at this time, as far as like if a woman gets COVID during pregnancy, is at higher risk for heart defects or some other problems with the forming of the fetus during pregnancy. There is a pretty large data set of over 1,000 women that was the NICHD, which is the National Institutes for Child Health and Disease, the MFMU, which is a conglomerate of about 33 hospitals across the country that study pregnancy outcomes. And then the study was called the GRAVID study. This was a retrospective cohort of 1,200 women at 33 hospitals. These women had severe or critical COVID-19 illness, and that was associated with an increased risk of preterm delivery with an adjusted relative risk of 3.5. However, many of these preterm deliveries appeared to be iatrogenic, that is caused by or recommended by the physicians taking care of these patients, rather than spontaneous preterm birth, which is what it would be if a woman just started to labor on their own and deliver preterm. This has to be taken with a grain of salt because right now the current recommendations for COVID management during pregnancy is that if a woman is having worsening maternal status, i.e. they need to be put on a ventilator or potentially moved from a ventilator to ECMO, if they're greater than 32 weeks, strong consideration should be given to delivering the mother at that point, which thus would be one of these iatrogenic preterm births. So you can see how this data is going to get really difficult to parse out. Is this increased risk of preterm birth caused by the COVID-19 illness as a physiologic pathway within the woman's body? Or is this one of our responses to best taking care of the mother and the fetus once they are ill with COVID? Now, I want to point out, this is for those cases of severe or critical COVID-19 illness. This is not necessarily a recommended treatment or a response that should be advocated for women who are at home with asymptomatic or mild COVID infections. So this data is by Sun et al. It was recently published in the Green Journal, which is the Journal of Obstetrics and Gynecology. This was actually an interesting way that they did this data. They took de-identified EPIC data, and this was deliveries from across Minnesota and Wisconsin between March and December of 2020. So they had over 200,000 deliveries from 2020, and then they compared it to the 3 preceding years, matched by month. So they compared about over 200,000 deliveries from 2020 to over 600,000 deliveries from those other years. Of this sample that they had in 2020, there was a 7% rate of COVID positive tests in these patients. What they were able to show is that there was no significant differences between adverse pregnancy outcomes in the women that were taken care of in 2020 compared to those women that had been taken care of in 2017 to 2019. And nor was there any problem in the adverse pregnancy outcomes between COVID positive moms versus the COVID negative moms. So this is going to be a little different than that other data set in that this includes all women with positive tests. So many of these women would have had mild or COVID diseases that they were affected, but not enough to be in the hospital. The outcomes they looked at in this study were preterm birth, stillbirth, birth weight, both small and large for gestational age, hypertensive disorders of pregnancy, placental abruption, cesarean birth, and postpartum hemorrhage. Now, shifting gears a little bit to what do we know about the vaccine and its effect in pregnancy? The biggest thing is that the vaccine is effective. This is UC Health data from last week showing the red little men here are the ones that have been unvaccinated. The gray are the vaccinated. So what we can show with this slide is that vaccination dramatically decreases the rate of being hospitalized for severe COVID illness, requiring an ICU bed and or requiring ventilation. And this has been shown in pregnant and non-pregnant patients. Specifically with the vaccine in pregnancy, the safety data started as some animal data on teratogenicity, which would be birth complications or structural complications, and that data was reassuring from the animal data. The initial trials, as many of us know, for the emergency use authorization that the FDA was initially approving for these vaccines, they specifically were trying to exclude pregnant women. Between the Pfizer and the Moderna trials, there are 2 to 3 dozen women that ended up being pregnant during the course of the trial that were continued to be included in the data, but that was not nearly enough of a study sample to say that they studied this in pregnant women. When the vaccine was released, however, in December of 2020, the FDA did allow administration to pregnant women, recommending this under a shared decision-making model. And this is how many, such as myself, decided to get the vaccine early on when it was initially distributed. Since that time, there's been registries such as the CDC's VSafe database that has been established to monitor the vaccination outcomes, including those pregnant women that received it. There are currently phase 2 and 3 trials studying these vaccines specifically in pregnant patients that are ongoing at this point. Since early August of this year, the CDC, ACOG, which American College of Obstetrics and Gynecology, the Society for Maternal Fetal Medicine, the American Council on Immunization Practices, and the American Society for Reproductive Medicine, and several other authorities strongly urge pregnant women to be vaccinated and have additionally called for data to better inform patient-provider counseling. Of note, in August 23rd of this year, the Pfizer-BioNTech vaccine, renamed Comirnaty, had been formally approved for all adults, including pregnant women, as of late August. So it is now formally approved and is no longer under an emergency use authorization. That is expected also soon for the Moderna and the J&J vaccines, but those are still being used under emergency use authorization. So this VSafe database program here is where the data came from for the initial publication on the safety of the vaccine. And this was published in April of this year in the New England Journal of Medicine. This is the closest I'm ever going to get, I'm convinced, to being published in the New England Journal of Medicine, as I was one of these 800 data points. So of the 35,000 people that had identified themselves as pregnant in this database, which is self-reported, there were about 827 completed pregnancies between December of 2020 and February of 2021. The vast majority of doses that had been administered in pregnancy were given in the third trimester. So this data is largely based on third trimester administration. What they showed here, and the way they did this is they compared the rates they saw in their VSafe pregnancy registry, which is this far column here, to published incidents of these outcomes before. Because again, this was not designed to be a study, this is a reporting of their observational data. But what they were able to show is that there was no difference in side effects between pregnant women and non-pregnant women, and that the rates for preterm birth and small for gestational age that were seen in those women that received the vaccine, again, predominantly in the third trimester, were no different than historical rates for these same outcomes. If you see here, the congenital anomalies, 2.2% is actually less than what would be expected for the population at large. This study was done in Minnesota and Wisconsin as well. This study was looking at vaccine safety, and it was published by Thiedler et al. In the American Journal of OBGYN MFM section in 2021. This looked at over 2,000 women that had received care between December of 2020 and April of 2021, about 7% vaccination rate in this population. They looked at a composite adverse outcome index, and this included several maternal and fetal adverse outcome measures. And they saw no difference between the vaccinated and the unvaccinated groups, except for the rate of COVID infection. So this is their adverse outcome composite. It was 4.9% in the no vaccine group and 5% in the vaccine group. But then obviously the COVID infection rate was different, which is the point of the vaccine. So they had about an 11% in COVID infection rate in their unvaccinated and a 1.4% rate of COVID positive tests in their vaccine population. Again, these were mostly for doses given in the third trimester because the median gestational age at this vaccine dose was 32 weeks. So the take-home messages from my bit here is that we've gotten better at caring for patients with COVID-19 infections, but it still causes severe illness in some pregnant women, and pregnant women have a higher chance of these severe complications. And vaccination is safe, and it's currently our best management strategy, both from a maternal and a fetal standpoint.
Thank you, Dr. User. Our next speaker on this topic is Dr. Jessica Cataldi. Dr. Cataldi is an assistant professor of pediatrics at the University of Colorado School of Medicine in the section of infectious disease and epidemiology. Dr. Cataldi's research focuses on how to improve immunization delivery and acceptance. Since March 2020, she has provided additional support to the Children's Hospital Colorado Epidemiology and Infectious Prevention and Control Group in the COVID-19 response, given numerous educational presentations for primary care providers, school health professionals, and community audiences, and worked with CDPHE, the Colorado Department of Public Health and Environment, as a subject matter expert on children and COVID-19.
Great, thanks so much. Let me get my slides up here. Okay, are those showing okay?
Yes.
Great. So I will cover some of the same ground and then focus on the effect on the neonate and also talk about how we can communicate about COVID vaccines. I am on the board of directors of Immunize Colorado, which is a community organization that promotes immunization, access, and education across the state. I have no other financial conflicts to disclose, and I'm not paid for that time as a board member. So again, I'll talk about the neonatal risks related to COVID-19 infection during pregnancy, the benefits for the neonate that vaccination can provide, and then also talk about what we know about transfer of antibody through breast milk and through the placenta, and then end with some discussion of how we can communicate and address vaccine questions and concerns that come up. So to share some data about the effect on the neonate, as Dr. User mentioned, some of this has been hard to tease out, particularly because the way that COVID-19 infection during pregnancy is managed has changed a little over the pandemic, and changes depending on how sick someone is when they become infected with COVID-19 during pregnancy. This was a study that came out earlier in this spring, I think it was April of this year, that looked at over 700 people who had COVID during pregnancy and compared them to just over 1,400 pregnant people who did not have COVID. And they did find a higher risk of preterm birth here. Again, as Dr. User mentioned, some of that is related to what happens if someone becomes severely ill with COVID-19 and then is sometimes induced or delivered early to try and protect the mother who is severely ill with COVID. But in this group, they did see a higher risk of preterm birth and higher neonatal morbidity index in the neonates born to people with COVID-19 during pregnancy. They also found a really high rate of infection among infants and did find that that was associated with C-section delivery. When we look at some other studies, that rate of vertical transmission or COVID infection around the time of delivery is much lower. So I think this 13% is probably a high estimate, but we do know that one risk of COVID-19 infection during pregnancy is passing that on to the baby more often in that peripartum period, more often after delivery, either through contact from the mother or contact from other family members or caregivers who might be infected. So thinking about the benefits of vaccination in pregnancy for the neonate, one is, again, that reduced risk of severe COVID-19 in the mother, which leads to a reduced risk of transmission and reduced risk of preterm delivery and the associated neonatal morbidity that we know that comes with preterm delivery. Other benefits include the transplacental transfer of antibodies, which I'll talk about in a minute. We know that infants are too young to be vaccinated for COVID-19 and for many other things. And so they can benefit from that passive transfer of antibody from the placenta to help protect them in the early months of life. And then also reducing that risk of postnatal COVID-19 infection for the baby, both in that immediate period after birth, but also in the months after birth when they're still young, their respiratory system is still developing, and we don't want them to get infected with COVID. So this idea of really vaccinating all of the adults around that infant can benefit the infant because we know that they won't be able to get vaccinated and be protected in that way themselves. We do have some data, thankfully, for that transfer of antibody from vaccination during pregnancy. So this was one study of 122 pregnant patients who received a COVID-19 vaccine during pregnancy. And what they did is test the maternal blood as well as the cord blood from the infant at delivery. And they showed good transfer of antibodies through that cord blood as long as it was at least 2 weeks after the vaccine had been given. They also showed in this graph over on the right that as more time passed between the time of vaccine and delivery, that transfer of antibodies increased. This has been shown in several other studies as well. So in these 3 additional studies shown here, between 30 and 130 women were evaluated in these 3 additional different studies. Again, looking at the antibody levels in breast milk and in cord blood. And they showed good transfer of antibodies in breast milk when it was measured, as well as in the cord blood. And then this graph on the right is showing a similar phenomenon where the more time that passes on that x-axis, from the time that the mom was vaccinated, the more time that passes, the more antibody gets transferred to the baby. So again, confirming that we have good antibody transfer through placenta and then also through breast milk. This is an ongoing study that is funded by NIH. It's called MommyVax. And it's a multi-site study. Unfortunately, we don't have a site in Colorado right now, but they'll be following pregnant people who receive COVID-19 vaccine and following them and their infants through a year after delivery. And in the infants, they'll be measuring not just cord blood, but also taking blood samples from that infant throughout the first year of life to see how long that antibody protection from COVID-19 lasts in those early months of life, and really following what their response looks like, and also following to see if they get sick from COVID in that first year of life. So this will be really helpful information that we'll have coming out in the next 6 to 12 months as these studies are ongoing. So shifting gears, I want to talk about how to communicate and respond to people who have concerns about vaccines. Thinking about the general causes of vaccine hesitancy, I like to organize them into how people might consider both the benefits and risks of vaccination, and then also the context that everybody brings to those conversations. So some people who might have hesitancy or concerns about vaccines might think, well, maybe there's not really that many benefits for vaccines, or maybe these diseases that vaccines are trying to prevent are rare. They're not things I've seen before. I don't know anyone who's gotten severely ill with COVID, so why should I worry? Some other people think, well, everybody else is getting vaccinated, so I don't need to worry about it for myself. On the balance, people are thinking about the risks of vaccines. For some people, it's really just this idea that they've heard so much information that make vaccines sound complicated that they have this overwhelming perception that there must be a risk. And that's understandable. It is really hard to sort through, particularly with the COVID vaccine, all the information that's coming out day to day. We always have other myths that have persisted around childhood vaccines, like the association with autism that raises concerns for many families, even though there's not really any true link between the vaccines we give and autism. Other people have concerns about how many antigens and how we're overwhelming the immune system, concerns about side effects from vaccines, about the toxins or chemicals in vaccines, or the idea that maybe the flu vaccine gives me the flu. And then, of course, everyone comes to this conversation with their own personal context, and it's important to understand that before you try to answer the questions that someone has. So many people have reasons to distrust the healthcare system in general, and they bring that to their conversation about vaccines. Others have challenges with access to care, and that includes challenges with access to information. Just because you might be able to go get a vaccine at a pharmacy, if you don't have a way to establish a relationship with a primary care provider, or a way to establish a strong relationship with your prenatal care provider throughout your pregnancy, you may not have had a chance to ask those questions and have those conversations. So when we think about all of that, we also need to think about how we're going to respond. So it's important to know how to answer the specific questions and concerns people have and know those answers, so the content of what you can say, but also to know how you can talk to people. What are the approaches and the techniques that are really most effective and that will really allow you to move forward together in a positive way? So understanding the answers to the questions that everyone has, unfortunately, is an ongoing challenge. New questions come up every day. And I have resources at the end of this slide deck that you'll have access to today and after today's presentation, where you can go read and look up those answers. So I'm going to focus now on what those techniques are and how we can communicate. One is knowing how to debunk myths. So the recommended method to debunk a myth is to really make a truth sandwich, so that you're focusing on the truth, saying the myth, and then closing with the truth, because you want somebody to remember the truth. So that's why you start with it, and that's why you end with it, instead of talking more and more about the myth, and then the myth is the only thing that sticks in their head. We also know that making a strong recommendation and an offer for vaccines helps, saying this is something I really recommend during pregnancy to keep you and your baby healthy, and here's why. And then the idea of social norms. So in pregnancy, unfortunately, we know that actually we don't have a majority of pregnant patients vaccinated yet. But for the overall US population, it is true that more than 75% of adults have chosen to get the COVID vaccine. That is the norm. That is what people are choosing. And so really focusing on that. And then when people have concerns, shifting to a motivational interviewing approach to really work with them about their concerns. And also knowing that you may have the benefit of using the relationship you have with someone to continue these conversations over time. It's not a one-off thing. You're not going to reach a resolution in one conversation with everyone, and that's fine. Many of you might know motivational interviewing techniques for other situations. And I'm just going to show some examples of how you can use these different motivational interviewing skills in a way where we talk about vaccines. So thinking about, for example, the idea of open-ended questions, you don't want to assume what someone is worried about because everyone has different concerns. So really starting out by just asking, what are your concerns today? What are your questions? What have you heard about the vaccine? Asking permission to share. So instead of just rattling off a list of facts or rattling off what you know, asking, would it be okay if I share with you my perspective on this or what I've seen during my own experience or for other pregnant people who I work with? Giving affirmations. Everyone wants to do what's best for their family. And when you're having these conversations, people want to do what's best for their baby. So really affirming that. Reflections, really reflecting back what you hear from someone. You know, someone has told you, well, I've looked in all these things, I've read all of this online, I've talked to my sister, I've talked to my friend. It sounds like you've really thought about this a lot, reflecting back to them what you've heard, and again, affirming that they want to do the best thing. And then summarizing where you are. So we've talked about this a lot today. I've talked about how the vaccine is important, but at the end of the day, supporting their autonomy, this is really a decision only you can make. So is there anything more you need from me today to help inform that decision? And again, this may be something you come back to over time. The other things that you can do are focusing on the benefits of vaccination. So really, as Dr. User and I have both talked about, those benefits both during pregnancy for the whole family and for the baby. Talking about those benefits and also sharing your personal choice around vaccination and sharing your story and your journey about how you made that decision for yourself and for your family. Talking about how carefully these vaccines were studied and developed and how they continue to be studied with a focus on safety, and then sending people to reliable resources to read more. I'm going to just leave this slide up here for a second. I'm not going to read it all to you, but I just want to point out that COVID vaccines, we hope, will be coming soon for kids, and they are important for kids. So any chance you have to talk about this early in pregnancy and early in that journey as a parent is helpful, because we really do need to keep kids protected from COVID too. Although they don't get sick as frequently as adults from COVID-19, there is a real impact on kids, and there is a real need to get them protected too. While we're waiting to get them protected though, it's really important to vaccinate all the adults around them. And that's why it's really great to start thinking about this during pregnancy. And again, the slides at the end here have lots of helpful links and resources. So I'll stop there.
Thank you. Thank you both. And I know there were some questions that were coming through that it looks like you may have answered. I'm not sure if you want to, verbalize any of those. Maybe others in the audience have similar questions about just, efficacy and safety, and reiterating some of that data that, is published, or studies that have been done. So I just want to pause for a moment if you want to speak to any of that that's come through the Q&A.
One thing I just wanted to comment on is, there was a question in the Q&A about how we know safety of these vaccines if pregnant women weren't included in the initial studies. A lot of this is based on our prior knowledge of immunology and how vaccines work and how we anticipate that they work. And so the mRNA vaccine, it's just another technique of showing an antigen to your body for it to make an immune response. And so we have used vaccines in pregnancy safely over decades, and the only vaccines that we try to avoid during pregnancy are those that are pieces of live virus that are shown that are part of the body. So the chief example, that's the chickenpox virus or the MMR, because of the rubella component and measles, some of those components in the MMR. So we have used vaccines in pregnancy for many years to protect women, and more so their babies. So for example, we recommend the pertussis vaccine or the Tdap to everyone in pregnancy, so that we can get those babies the whooping cough protection for when they're born, because as Dr. Cataldi said, the first several months of a baby's life, they are not eligible for many vaccines yet. And we want to make sure that everyone around them is protected and that they have some passive immunity to that. So we have felt very comfortable with vaccines in pregnancy for a long time. And so looking at this vaccine, there wasn't any biologic plausibility to concerns based on the way the vaccine works. And it's been helpful to demonstrate that we have the passive immunity and the antibodies in the cord blood and the effect in the babies, but that was not a surprise to people in this field, because that is how other vaccines work to protect both mother and child during this time frame as well. So for those of us in this field, the use of vaccines in this way is very standard and has been part of prenatal care and recommendations for many years.
Thank you. Another question just came in about timing. So if a woman received a vaccine prior to getting pregnant, do the antibodies still transfer to the baby? And if not, is it recommended to get the booster while pregnant to support this antibody transfer?
So we don't know exactly, because this is obviously still an ongoing kind of data collection time that we're all living in. The body will make antibodies to vaccines over a several month period. So depending on the time frame between when someone got it before they got pregnant and that time frame, you could anticipate that there would be some antibody transfer to the baby. And Dr. Cataldi may have better specifics on this based on her niche of medicine, but we would anticipate there'd be some protection to the baby with vaccination even prior to pregnancy. Now, how long that lasts and what the benefit of a booster during pregnancy may be, we don't 100% know yet, but you would expect another boost in the immune response to a booster. And so that potentially could increase the effect again. That's not, to my understanding, one of the groups that has been approved for the booster to this point. Pregnant is not in one of those categories at this point. And that may be because while there's an additional benefit, it's not as much additional benefit as the groups they're trying to target with the booster at this point. I personally know someone who received the vaccine at 5 and 8 weeks of pregnancy, and their baby was still born with antibodies as well. So we know that response has a fairly long latency to it, but it would depend on a particular situation to how far in advance before pregnancy they got the vaccine and what we could anticipate for their baby.
Yeah, I would echo everything that Dr. User just said. We know that, for example, when moms have had measles vaccine very early in life, they do transfer some of that antibody transplacentally to the baby, but the amount of antibody you transfer is much higher, for example, when you get your pertussis or your flu vaccine actually during that pregnancy. So I think it would be expected that there would be some likely level of transfer, and depending on how much earlier or how much before the pregnancy you got vaccinated, the actual quantity is going to be higher or lower. And then as Dr. User said, right now, we don't have a recommendation for someone to get a booster, either because they're now pregnant and were not when they got their first series, or to get a third dose if they got their first 2 doses earlier in pregnancy. Right now, that's not recommended, but it is something that the CDC continues to look at over time. And it is a question that came up several times this week as CDC was discussing those recommendations. And I'll also point out, I can put a link in the chat in a second, but the CDC spent some time, I think it was Wednesday, the first half of their meeting this week, focusing again on the updated safety data around these vaccines during pregnancy. And those slides are all public facing, so I'll put a link to that in the chat.
Great. And could you discuss maybe some of the most common fears that you're seeing among your patients and pregnant population, or folks who've maybe just had a newborn, an infant?
Yeah, I think, there's a general thought that we don't want to take anything during pregnancy, and that we don't want our patients to take anything during pregnancy. And the way I frame this to my patients, and again, many of my patients have complicated pregnancies, so they have other medical disorders that we're taking care of as we're working through their pregnancy. But my general kind of thought on this is, if we lived in a perfect world, yeah, I would rather give you nothing different during your pregnancy, because that's going to be the, best way to make sure that everything is good. But we don't live in a perfect world. And right now, our choice is not to not get the COVID vaccine or get the COVID vaccine with 0 other repercussions. The choice is the COVID vaccine or running the risk of getting a severe COVID infection of yourself, which could also pose very real risks to your pregnancy and potential complications. So it's a little bit of a false argument to only be arguing about the potential risks, because none of these have been shown to this point, arguing the potential risks of the vaccine or any medication during pregnancy, unless you're really comparing it to what would happen if you have that disorder and aren't appropriately taking care of it. And so I think it's not a question of the vaccine versus no vaccine. I think it really should be framed more of a question of the vaccine versus what if you get COVID, and that is the other side of the equation. And I think when you talk about it that way, it's a little bit of a different discussion. Also, I think a lot of women aren't always aware that their body can do such a good job in service of passing these antibodies on to their baby. And so more recently, I've started to frame it as, no, I actually want you to get the vaccine because you are pregnant, because you are a more vulnerable population, and because this is your one chance to get your baby these antibodies. I don't know when my 8-month-old daughter is going to be of an age where she's allowed to get the vaccine. And so for right now, that's the best thing I could do for her to protect her, is to get her those antibodies by getting the vaccine myself. And so I've tried to reframe it in that way right now, because these children that are being born this year and next year, it may be several years before they're eligible to get the vaccine themselves. And thus this in a breastfeeding exposure to the antibodies is the one way we can get those babies that protection.
Dr. Cataldi, I'm not sure if you have any comments to add to that in terms of, some of the most common fears that you're hearing about from your patients.
Patients are kids, so most of them aren't, sadly. But I do think that everything that Dr. User said rings true from the work that I have done with other maternal care providers. And I would say the other thing that I hear from parents when they're thinking about the vaccine for their kids, just recognizing that a lot of folks on this call probably have that experience either in their professional or personal lives, is, why do kids need it? COVID isn't that severe for kids. And again, I guess I would just really like to dispel that myth. Compared to adults, kids have a better time with COVID. Compared to all the other diseases that we try to protect kids from, COVID is also very bad. So, if we were talking about, how many kids die a year from COVID, well, over 500 kids have died in the US now from COVID, and the numbers are increasing over the past several months. We're at the point now where about 20 kids a week are dying from COVID across the US. That is much lower than the number of adults dying from COVID, but I would still say that's 20 kids too many. And when we compare that against other diseases that we try to protect them from, against things like car crashes or all the other things we do around safety for kids, we really want to protect kids from COVID too. So again, in the meantime, let's get everybody around them vaccinated. But I think that's kind of the most common concern and question I get for what's going on with kids. And then everything Dr. User said, again, is similar questions I'm used to hearing from pregnant patients.
And I think too, because so many people have had exposures to people with either mild illness or asymptomatic COVID, it's hard for them to conceptualize how very serious this can be. And it's very difficult in that it's hard to know who's going to have a serious case or who's going to have an asymptomatic case. And so it's sad but true that I've spoken to more than one patient who said, I didn't think it was that big of a deal. And that's the last conversation we're having before they're getting intubated. And we're talking about delivering their babies while they're sedated, because that's what is necessary. And so I think sometimes in a way that still protects my other patients' privacy, to be able to share, no, there are some very sick women that I'm taking care of right now. And they woke up a week later and we had to tell them they had their baby because they were asleep and intubated that whole time. I think just sharing some of the actual worst case scenarios that unfortunately some of us have to take care of can sometimes make them realize that there is a really potential severe outcome for some people.
Yeah, thank you. And our final question is, if the pregnant person does not want to get vaccinated, how do you counsel them about staying safe?
It's all the things we learned about before we had the vaccine. So trying to limit your contact with others, trying to make sure that you are 6 feet away, that you're doing as best you can to wash your hands, not touch your face, wear your mask, live in a bubble, essentially. Those are all the things that would be recommended if you're not choosing not to get vaccinated. I think if someone is concerned, even getting vaccinated post-delivery and potentially using the breast milk to pass some of those antibodies on is going to be better than not getting vaccinated at all. But I think that is recommendations in that situation would be living in the time pre-vaccine, which we all were in, as far as how to protect yourself.
Yeah, I think the only thing I'd add to that is you could try to cocoon that pregnant woman too. So if you really find that, you can't overcome whatever that concern is, saying, I understand that you may view sort of your own personal choice different during this time when you're pregnant. However, it would really benefit you if everybody in your household or everybody who's around you day to day, the other people who are going to be taking care of you and your family are vaccinated, because that also decreases the risk of their exposure while they're pregnant. And then I do want to address this question though about should you skip the vaccine if you've had COVID before? We have good data that you still need the vaccine. So we know, unfortunately, that a proportion of people who have COVID do not keep a lasting immune response, and that durability, that lasting immune response is stronger after vaccination. There have been a couple of studies now that look just at rates of reinfection among people who've had COVID, and it's at least 20% after about 6 or 8 months. We have antibody studies again to show that some people, including people who've had mild infections, and then a lot of people who've had severe infections, actually don't form a memory immune response, unfortunately. And then there was also a study that came out from Kentucky a few months ago that was looking at that rate of breakthrough infections among people who'd had prior COVID versus who'd been vaccinated, and it was higher among people who'd had prior COVID.
One quick caution for the people that think about maybe cocooning the pregnant woman and just not vaccinating the pregnant woman and vaccinating everybody else. Everybody else still has to live like they don't have the vaccine either, because they can bring home breakthrough infections if they're off out in the world, not, taking those same precautions. So I have a patient whose entire family was vaccinated. She was the one unvaccinated person. Somebody got infected even after vaccination, and she was the one person hospitalized for a week and a half. So it can still happen even after vaccination that you are infective. And so that's still a potential concern in those situations.
Thank you, Dr. User and Dr. Cataldi. So informative. And I wanted to acknowledge one other comment that just came through. There are a number of resources. I've seen some of you started posting those from CDC. HRSA has some as well, different language for urban versus rural patients or communities. And in case you weren't here when we did our introduction, CPCQC has just received supplemental funding from the CDC for a 12-month project to